Welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture between Path Presenter and the Digital Pathology Association. Our case today comes from the realm of soft tissue pathology, and perhaps is a challenge, perhaps not. It's an elderly man with a slowly enlarging thigh mass. It actually has gotten quite bulky. He's a bit of a crusty old gentleman from a rural area of our state. And so on radiographic evaluation, as you can see, this is a little bit beyond obvious that there is an abnormality. And here you can see on these MRI-weighted images with the fat saturation that the tumor contains a great amount of fat and has a somewhat atypical pattern, although it does seem to be respecting many of the boundaries with adjacent muscle groups. Additionally, on the fluid sat images, we don't see any particularly sharp fluid collections, no cystic component. We don't see any other solid components. And so most likely this is a entirely fatty neoplasm without any evidence of cystic changes involved. So what do we think of in this situation? Well, I think there are a couple of things in the differential. Intramuscular lipoma certainly would be a possibility, although this is quite large for a single intramuscular lipoma. And of course, the most obvious diagnosis would be atypical lipomatous tumor / well-differentiated liposarcoma. Now, other lipoma variants, spindle cell and so forth might come into play as possibilities, as well as other fatty tumors such as myxoid liposarcoma, although that might usually have a slightly different signal intensity. And unusual in this location, but also a consideration, a hybrinoma. Again, quite unusual in an elderly gentleman for those lesions. So certainly we're thinking here atypical lipomatous tumor. At resection, marginal resection was done. And you can see that indeed it does have this nice lobulated appearance, a little bit of smooth, thin tissue along the surface. And it's obviously quite bulky, coming in at well over 40 centimeters in terms of maximal dimension. It did shell out fairly easily and no particular involvement of the neurovascular bundle or other compromising areas was needed to be damaged to remove the lesion. So here's our histology. And as expected, it has a very pale, fatty appearance. We don't see a lot of fibrous bands. There's just a little trace of one down here, some slightly increased pink material in a few areas, but no typical fibrous banding on this lesion. And as we come into higher magnification, you can see that this is mostly mature looking fat. But as we look around, we see there are a few atypical cells here amidst the fat. Some slightly enlarged nuclei. And coming into some of the more cellular areas, we can see that, again, there are a few of these atypical cells, not very striking. So you still could be wondering, could this just be intramuscular lipoma as a possibility, because these atypical cells are not very striking. Looking into the stromal areas here at the bottom of our field for characteristic atypical stromal cells. We can see on higher magnification here, you got a few atypical cells around here in this, not very striking, even in these more fibrotic band areas. Here again. We'll go to one other area and zoom in on that to let you see again sort of the nature of the cellular infiltrate, which is, or cellular tumor, which again, as we see here, a few atypical cells, some enlarged nuclei, although these per se are not diagnostic of an atypical lipomatous tumor and can in fact be seen in many benign fatty tumors, sort of slightly open nuclei with little micro inclusions. But cells like this probably should not be seen in normal garden variety lipomas. Just to be sure and assured in this lesion, we did do MDM2 fish testing, but this brings up an important discussion about atypical lipomatous tumor because this is obviously what is also referred to or has been previously referred to as well-differentiated liposarcoma. In fact, these are two histologically and molecularly identical lesions, but they have a rather different biologic behavior. So in the retroperitoneum, in the thorax or paratesticular areas, use of the term well-differentiated liposarcoma is undoubtedly a better term because these have a fairly high recurrence rate. They are more prone to develop dedifferentiation and hence to be a problem in terms of limiting the survival of the patient. In contrast, a typical lipomatous tumor is definitely the preferred term for lesions that occur in the extremities, where the risk of recurrence is very low, dedifferentiation is very uncommon, and there really is no metastatic potential. Histologically, as we've tried to illustrate with this slide, you tend to see mature fat with occasional fibrous septi. They can be rare, as in our case, and there will be atypical cells, enlarged, slightly pleomorphic, occasionally binucleate cells that will be evident within those fibrous septi and occasionally out in the fatty parenchyma. MDM2 rearrangement is easily demonstratable by FISH or by PCR if need be. And immunohistochemistry can frequently be positive for the same protein product, as well as demonstration of CDK4 and P16. Now, a significant differential exclusion is that they would be negative for HMB45 and thus not fit into the PCOMA category or the other atypical lipomatous tumors. And of course, you want to make sure that you do not find any solid or dedifferentiated areas. And so sampling appropriately is necessary. So our final sign-out diagnosis for this tumor from the extremity, best termed atypical lipomatous tumor. Marginal resection in this circumstance is perfectly appropriate. Follow-up will be intermittent, but should be no problem for recurrence in this setting. Well, we hope you enjoyed that. And if you do, please hit that subscribe button so that you'll catch on to future releases. If you like it, please also give it a thumbs up because that helps other viewers to locate our material as well. And as always, we welcome your follow-up and your feedback, reaching out to us directly here at the University Health Center or by comments below. So until next time, thanks so much for joining me.